conversation, and if Edwin is able to join us, he can continue with us at that time. So my name is Jay Ben-Zion, and I am a life extension activist, and also I am the vice chair of the United States Transhumanist Party, and I am the presidential candidate for that party. In the course of the last year, I've spent quite a lot of time working on policy proposals designed to set the stage for a world that can sustain a universal super longevity, or do what little that a policy maker might in this area. And yesterday, I was lucky enough to present 2 times here at TAFFD on some of those subjects, including one quite closely related to the subject that we are to discuss today. We are going to, in just a moment, introduce our esteemed panelists and discuss this problem of that is racking the entire world in a certain way. The United States, it looks like a few more folks are joining us. The United States right now has, of course, the most fatalities of any place in the world for this COVID-19 pandemic. That number is pushing up to 50,000, and there are quite nearly 1 million people infected here in North America. This situation has gotten so dire that both of our neighbors to the north and south, Canada and Mexico, have closed their borders. They have lower infection rates, and many of us are reflecting on the past few weeks and months and wondering what we might have done differently to avoid being in this situation. And some of the things that I've discussed in these earlier talks have been to describe the systemic concerns with economic policies and other things that would have allowed for a healthier middle class and a healthier United States as a result. But I think that it behooves all of us to consider the future as well, and what we might do to prevent concerns of this kind moving forward. We know that COVID-19 is an age-related condition, and we know that we don't do as much as we might to prevent the ailments that derive from aging. And so this panel is designed to discuss the specific locales throughout the African continent and how we can be more proactive and consider public health initiatives of various kinds in the private sector, in the public sector, public-private partnerships, and all manner of initiatives that could improve that situation. Let me now take a moment and introduce our panelists and say hello to our other guests. Anonye.
Hi.
Welcome. You're looking very well. How are you this morning?
I'm doing great, Ben. Nice to see you. How are you?
I'm pretty good. I've got my coffee, so all is right in the world. Can you tell us, for the sake of our listeners, tell us from whence you hail, a little bit about yourself, if you wouldn't mind?
Absolutely. I'm actually originally from Nigeria, but I migrated to the United States about 30 years ago. Right now, I live in Virginia. I used to live in New York. When I came to the United States, I was barely a teenager at that point, and I was a nurse's assistant. Actually started as a nurse's assistant in a long-term care facility. So after a couple of months, I went ahead to become a registered nurse. And then I went ahead to get my master's degrees. I became a family nurse practitioner. So now for a period of, I think, 18 years now, and I've worked as a family nurse practitioner. Prior to that, I worked as a registered nurse for 10 years. And I've worked in so many different settings in the healthcare. I've worked in a subacute setting, pediatric setting, emergency room. Now I work in retail clinic setting. So that's pretty much the long and short of who I am. I write books, if that really makes a lot of at this point in terms of the topic we're talking about. And a lot of my, the two of my books rather are on preventing anxieties and fears in different sectors. So I thought that this would be a very good forum, for me to at least put in my 2 cents in terms of what the effect of this COVID-19 will be in the healthcare setting, in the general population, so to speak, because there's been a lot of fears and anxieties that are emanating from this, pandemic. So I thought it was something I could at least get on and at least talk a little bit about, what I can offer, if anything, to help alleviate some of the unforeseeable fears that will linger for many, many years, post this pandemic. There's still going to be a lot of fears, logical fears that we have to deal with, and hopefully put some resources in place to help us begin to manage these, unforeseeable fears for the future.
Mm-hmm. And there's been a lot of talk in recent weeks about essential and non-essential workers. A person in your field is rightly regarded in this moment, and I think for all of time, as the most essential of workers. And you also, as you mentioned, reside in a place that's been among the most impacted in the world by the COVID outbreak, and certainly in the New World. The New York, New Jersey, greater New York area has been has had a lot of difficulties. How are you feeling? How is your anxiety? How is your reaction? What is the read of what is happening on the ground right now where you are?
Well, I resided in the New York area about 9 years ago. I'm now in Virginia. So my daughter is still in university, so that's, a lot of anxiety to all of us. I basically call her every other day, She's not an essential worker, so to speak. Thankfully, gets to stay while we're out. But here in Virginia, I am an essential worker, so I still go in days very often. So the fear is real. I see that a lot of people are pretty much just scrambling at this point for information that will help soothe some of these fears. And there's just a lot of, I don't want to say conflicting information. I think the idea is to make sure everyone understands that the source of where they get their information, make sure just feeding themselves so many conflicts data and information that could just raise their anxiety levels. But it's there, the fear is real, and thank God there is a triaging process in the location where I work. So that way we're able to identify people who are supposed to go in strategic locations to either get tested or proceed to treat people who don't fall in that category. Based on their ailments and their presentations. But it's there. People are scared, rightfully so.
It's regarded as something of a tragedy here in the United States, the state of the testing, the availability of testing, and a lack of clarity as to triage methods in this moment in history as a result. And that is quite sad, and I thank you. I thank you for continuing to do this work. And even though Virginia is not quite so bad as New York, where you previously resided, still this is an incredible service that you're doing. I have some more questions that I'd like to ask you, but let's turn to our other panelists and say hello as well for the moment. Brenda, good afternoon. How are you?
Hi, I am good. I am good.
Yes, yes, you're looking well. For the benefit of our listeners, tell us where you are and a little introduction of yourself.
So I am in South Africa, Johannesburg, that's where I'm based. From a background point of view, I'm a risk and governance specialist. And I'm also the managing director of a company called Delio Consulting, where we specialize in advisory and also a little bit of digital as well. So as far as health is concerned, I've been involved. So a few of my clients happens to be in the health sector. And my interest has been, one, as a service provider from a process and digital point of view, and also as a patient, as a user of that service. I mean, I've had experience from both public and private sector. You know, the experience vary. There's a huge gap between the two. And also, even though I am currently residing in Johannesburg, I come from a province called Northwest, which is mostly rural. And, you know, when you look at the service that you get when you are in those areas that are mostly rural, and then you come to what do I say, the cities, there's a huge gap as well as far as, you know, access to health services, the infrastructure that you get, the kind of processes that people, you know, will have to go through or follow. So yeah, so there's a bit of background from me.
Mm. And we know that the African continent has not been impacted to the extent that Europe or North America have been by COVID-19 at this time. There are just south of 26,000 infections by the current reckoning. And while this outbreak is not so bad, some countries have been affected to some degrees. South Africa is second in deaths, although those deaths are quite low at less than 100. What is your sense being in South Africa of the impact in public health? Are anxieties running high? Are there concerns for shortfalls at this time due to this outbreak? Where do you think this might be going? Sorry, that question is also for Brenda.
Yeah. Okay. So as I mentioned, I am in Johannesburg, and that happens to be the epicenter at the moment for COVID-19. And South Africa in the whole continent seems to be the biggest hit by COVID-19. And there is fear, but you know, so there is real fear because we see people starting to, the numbers, you know, the death toll starting to rise. And I mean, in the past week, we have seen the numbers even of confirmed cases going up. Might be the fact that, you know, the increase in the testing, there's an increase in the testing of people across the country. But also, you know, what we've also seen is the efforts that the government is putting in terms of ensuring that there are safety measures. For example, when we started, our lockdown was meant to be 21 days, and it was extended by 2 weeks. This evening, we'll be getting an address from the president, which everybody is assuming it might be an extension, even though we also are looking at how do we reopen the economy. So yes, people are scared. The reason why I had a but earlier on is because depending on where you are, again, what you see in the cities is different to what you see shown in the rural areas. So one of two things, it might be because of the education, therefore people are not taking this very seriously because they don't know enough about it. There's not enough information about it. And that is also exacerbated by the fact that there's a lot of fake news that are flying around. So that, it's also making people to, not believe some of the information that they get in to say, there's an agenda here, is it real, is it bad? But more in the cities, you're starting to see people are, obeying the rules as far as the regulations for the lockdowns are concerned. People are coming forward and making sure that they are tested. People are staying home and ensuring that, they do what is expected of them. So where I am currently, there is real fear. There is a lot of effort that's been put in, both by government and the citizens themselves, to stay safe and make sure that we can flatten the curve. But as far as the outside, the provinces that are in the outskirts, it's a totally different conversation. It's you get areas, pockets of understanding and people that are just saying, you know what, it is what it is. We'll just continue with life, as it was before. So yeah, there's a mixture of both.
Mm-hmm. And your country, South Africa, has a universal healthcare system. It has a two-tier healthcare system where there is a public sector coverage for the vast majority of the population, and then some folks who opt for a private sector healthcare coverage. In this moment in history, with new concerns, new ways of addressing a pandemic, Brenda, and your expertise in this field of public health, do you see any emerging subfields or related disciplines like telemedicine becoming more viable in your marketplace, more cost-effective? Do you think that people might be taking an active interest in any new areas of medicine as a result of what's going on in the world right now?
Actively, no. And this is just based on my experience. Actively, no. There's a huge, like I said, disparity between private and public sector as far as health is concerned. And yes, the government is trying to get to a point where they will implement this national health coverage or insurance to ensure that they close or they narrow that gap between the private sector and the public sector. But as we sit here right now, there's a huge gap. And as a result, you find the private sector will steer towards these new initiatives, and they will grab that. And obviously, they can be afforded by a certain sector of the population. And then, almost to an extent that it's as if the public sector couldn't care less. They've got different goals. They have different priorities as far as investing in health is concerned. When you just visit the health facilities, the kind of service that you would get in a public sector versus the kind of service that you would get in a private sector, it's quite alarming. It's quite painful to watch or go through. So at this point, no.
Mm-hmm. Yes, and we do know that the United States does not have this level of universal health care, and it's not entirely clear how much that the holes in that system are contributing to these this high mortality rate in the United States, these 50,000 deaths, and that number is likely to continue to grow quite a lot. But we also do know that the mortality rate for people of a lower socioeconomic status is 3 and 4 times that of people who are more economically secure. And I think that goes back to what you just said. We need to take a hard look at how we are constructing these institutions and here in the United States, and to from around the world to all of our decisions. And again, thank you all for participating in this conversation. And we will be getting more to this idea of life extension in these contexts as well. But let's turn to some more of our panelists. I see Edwin is joined us via video. It's good to see you, sir.
Hi, everyone. How are you?
I'm pretty good. I'm pretty good. How are you this afternoon?
I'm doing well.
Yes. For the benefits of our audience, tell us a little bit about yourself and where you are, and please give us an introduction.
Hi, so my name is Edwin Uri. I'm currently in Monrovia, Liberia, on the West Coast. I'm an attorney, and I work in Liberia as an attorney, and I do some entrepreneurial stuff as well. So yeah, I went to school in the United States, and I go back and forth between Africa and the United States. And I've been here for about 5 months now, throughout the coronavirus process. So yeah, I would say, I'm 32 years old. I don't know what else to say about myself.
Perfect. Perfect. And I'll put to you the question that I put to Brenda a moment ago. How are people feeling right now in Liberia? There's less than 10 deaths in this country, and just over 100 confirmed cases. How is ordinary life being impacted? What is your impression of this?
Yeah, so it's interesting. We have basically have a 3 o'clock curfew. So, you go to the markets and everything, and people are there. It's very crowded. And people are carrying on, day-to-day activities until 3 o'clock, and then everybody goes home. So it's a weird thing because Liberia had Ebola, right? And so that's led to really interesting dynamics in how people respond. On the one hand, there's a lot of paranoia because people talk about actually being on the side of the road and seeing trucks filled with bodies being transported out of the cities to be cremated during Ebola. Because we have a population of 4.9 million people, and we have 44,800 deaths for Ebola. So it's 0.1% of the population. In America, it'd be the equivalent of 330,000 deaths or something around there. So there is that scar, but then there's, and it's led to a really interesting disease response pandemic where if you're on a main road, in a lot of communities where you branch off, there will be ad hoc, I don't even know what to call it, but I guess sanitizing systems where people just literally put a road, like a bucket on the side of the road. There's a rope, and they'll literally stop cars and suggest that you wash your hands before you come into their communities. And this is just stuff people do on their own. At major intersections, they're literally, I think for these people, the government should probably provide their materials, but just offering people the ability to wash their hands. So sometimes I'm in a car and I don't, before the 3 o'clock curfew, without getting in my car, I still have the opportunity to wash my hands 3 or 4 times from going to the store or whatever. So on the one hand, people really take it seriously, but then there's also a sort of fatalism. I don't even know if it's fatalism. People are just like, well, if Ebola didn't, mess us up, this certainly isn't. And there's some logic to that. Most people who die are probably wouldn't easily survive in the conditions that a lot of people in Liberia So yeah, I would say that that's been my sense of the entire thing.
And those are very interesting insights. And I have more questions for you, but let's say hello to our remaining panelists.
Okay.
Aubrey, how are you, sir? Can you hear me?
Yes, I can hear you.
Yes, yes. You're looking well. Tell our listeners a little bit about yourself, where you are.
Okay, I am Oji Ama Ono Chinedu. I'm from Nigeria. I reside in Nigeria, presently in Lagos, but I'm from Abia State. I'm an aborigine of Abia State. I graduated from University of Lagos in 2015. Thereafter, I proceeded to Nigerian Law School. I'm a lawyer. I did my national youth service in northeastern part of Nigeria, Taraba State precisely. Taraba State is the second largest state in Nigeria, and after Niger State. Niger State is as big as Netherlands. I was the best corps member in Taraba State, best corps member in the whole state. I hosted a workshop that led to the release of different inmates. Former Chairman National Human Rights Commission, Professor Chidi Odinkalo, was the guest speaker. I started up a radio show, which is still operated till now, to raise awareness on human rights violation. The radio program was titled Know Your Rights, and came back to Lagos in 2008. I partnered with my uncle in a law firm, and within the short period of my legal practice, I've been exposed to different horizons of legal practice, such as property law, commercial law, and what have you. And I'm a human rights activist. I'm a core nation builder. I've taken plethora of pro bono cases. I've done a lot of pro bono cases for indigent inmates and clients alike. And again, unlike Trump, I'm a globalist. A globalist. That's all. And we are in together this coronavirus thing, and Lagos is not an exception. Nigeria is not an exception.
Yes, and the country where you reside is the largest country on the African continent, and the city where you reside is a city on the African continent. You mentioned that you've had done some work in both this urban and also rural areas. What is your impression of the impact of the coronavirus on people's ordinary lives in Lagos or outside of Lagos in the more rural areas? Is it affecting people in a rural area to a high degree? Is it something that's on their minds?
Okay, when it comes to Lagos, here in Lagos, Lagos happens to be the hotbed of the coronavirus, because Lagos is like the 50% of commercial activities in Nigeria, or 85% of the commercial activities in Nigeria happens here in Lagos. The wealth of the nation resides here in Lagos. So anything that affects the country, first of all, comes to Lagos, most especially something coming out outside the country. Like we had issue with Ebola. It was here in Lagos, and which was effectively handled very well. The coronavirus pandemic has crumbled commercial activities here in Lagos. We are on lockdown. The state is in total lockdown. No commercial activities. We have places like Ogun State and Abuja, the FCT. But Lagos State shares the largest chunk. We have like close to 500 cases. But we have made some really good progress, because a lot of people have recovered. We have recorded 22 deaths up to now, and we have recorded more than 200 people being discharged from the hospitals. Going further, you mentioned rural area impact on rural area. On rural area, I will use my state as a case study in Abia State, because most Lagos, we don't really have rural areas here in Lagos. In Abia State, we don't have coronavirus issue in rural areas. We have only 2 coronavirus in Abia State, and the same thing due to other rural areas in Nigeria. We don't currently have coronavirus cases in rural areas. It's only up in urban areas. In urban areas, like we have in Kanu, we have in Ogun State, we have in Awka. Awka is the capital of Anambra State, and some other urban area. But as it stands now, we don't have coronavirus in rural area. And the states, most states, not just Lagos, other states are also on lockdown. Yesterday, the 36 state governors met, and they agreed to lockdown, that the respective states should be on lockdown. Before that, states like Lagos, Ogun State, and FCT, as I have earlier mentioned, are on lockdown. Like here in Lagos, we have been on 5 weeks lockdown in Lagos, and it has really impacted negatively on commercial activities. Nigeria, as you all know, most people know, is a monotonous economy. Currently, the oil is below $1 per barrel, and you know what that means. And we don't even, the internal activity, commercial activity is not even going on, and it's really hitting hard on us. Again, we don't have Nigeria, we don't have that. I'm sorry to say that we don't have a responsible leadership, because you can't just tell people to sit down at home, not to do anything, because most Nigerians live on subsistence living, earning, day-to-day earning, and they have not provided any palliative. The government have not provided any palliative, and most of the, they said is on paper, they said they have provided palliative, and is nowhere to be found. Is nowhere to be found. And you go to the street, people are not getting anything. It's like as if they have embezzled the money. The same narrative all over Africa. Most of African countries are having the same thing. South Africa, people are protesting. And this is the problem we are having in Africa and also in Nigeria. The lockdown is affecting us negatively, commercial-wise.
Mm-hmm. Wow. Yes. And I have further questions for you. Thank you so much, Aubrey. But let's say hello now to Kelvin. Last but not least, Kelvin, thank you for joining us.
Hello.
How are you?
I bring you greetings from Delta State, Warri in particular. My name is Kelvin Ogba Dafiago, the founder and CEO of the Ogba Educational Clinic and chief promoter of artificial intelligence and the monstrous changes bringing into our world in Africa.
Yes. Can you again state for everyone which where you are right now?
I'm in Delta State, Warri in particular of Nigeria.
Yes. So we have folks who have had different looks at different parts of Nigeria, and may have some insights into the workings of public health, and that's really wonderful. And is there anything else that you would like to say, Kelvin, about?
Yes, I'm in the rural part of the Niger Delta area, and here my brother has said a lot, but I want to look at the lockdown in particular. There has been series of robbery, series of stealing of properties, breaking and entering, and all that. Lots of people are hungry, and I think the present government is not doing well enough. If you look at it from the angle that people are hungry and are unable to access food, and the food that was given as palliative measures to be given to the poor people are actually being diverted by some politicians, this makes someone to have just a small tin cup of milk as food, then I know that we are in for a big shit. This also brings my mind to what Bill Gates' wife said, that there will be deaths in all over Africa, and then we heard ministers or pastors condemning him and saying it will not happen. My whole idea about this thing is that Africans should not just sit down and say, no, it's not going to happen. Oh, why are they going to mass? Oh, why? So that's why we decided to set up the Ogba Educational Clinic and the Artificial Intelligence Hub to disabuse minds of people. Let's get talking. Let's talk about COVID-19. Is there a conspiracy? How are we going to handle it? How is life going to be after COVID-19? Because there's going to be a life after them. When I tell my people there's going to be a post-COVID economy will collapse. Governments will sack workers, will be unable to pay workers. My friend in Lagos, I just said that the oil price is less than $1. So how will the average young man survive in this era? That also brings us back to training the people with the future job skills to prepare them for this kind of change that would happen. So a lot of negative things are happening over here. There's lockdown, people are unable to access basic needs. Here we have problem with power, we have problem with internet connectivity. You must have seen how I was going off and on, up and down. It's really a big challenge. It's more and more difficult for them to be able to stay locked down peacefully. It's a huge challenge. But then the majority of the people don't even understand what is lockdown. Lockdown to some is just means to go out to the field and play ball in the evening and all that. But in abroad and in developed world, there are better measures, better palliative measures to really make them comfortable during lockdown. But imagine a lockdown without power supply, without good internet connectivity, without food to eat, without basic needs. So it becomes very difficult here.
Yes, and thank you for these insights, Kelvin. And this is an important point that has been made by our panelists. Although the number of deceased in these countries may be low at this time, the impacts are very real. As Aubrey alluded to, and also Kelvin alluded to, the total deaths in Nigeria is about 25. The total confirmed cases is just under 800 by our current measures. But yet we are seeing impacts on
because there are fewer
urban, yes, on urban life, and this what you mentioned about social programs to assist in this difficult time when people are not allowed to go about their ordinary business. This is an important point. And there have been basic income pilot programs in Africa, famously in Kenya, and other undertakings of this kind. And I, for one, am an advocate for programs of this kind. And I think that this conversation has been advanced in the recent months in the wake of the COVID-19 pandemic. But I hope that it will continue to be at the center of the conversation, because it is important in whatever form it takes. People do have to live and do have to continue to go about their business. And and I thank you all for these insights into this. Let's go back round to Nonye. And you have an understanding of the working of public health systems in the United States. Last week, the president famously reversed this very long standing funding for the World Health Organization, and this created quite the international furor. Some other countries at that precise moment agreed to up their funding to the World Health Organization. What role do you think that bodies like the World Health Organization should play in epidemics, maybe this epidemic or other concerns on the African continent? Do you feel that they have done good work? Would you like, what is your impression of the role of the World Health Organization at this time?
Well, you know, I have to be very honest, you know, with you. As a clinician, for many, many years, I have, you know, pretty much focused a lot on observing patient behavior in healthcare settings and how different activities in life or even historical events can affect behavior in healthcare and how that can translate also to, you know, engagement patterns that we see that can inevitably bring about cases of some communities being underserved when it comes to healthcare management. When it comes to the WHO, I really am not into a lot of the public health sector observations. I haven't quite, you know, just like the average person, you know, I will watch the news and just to see the impact they've had so far and the administration's views of the impact that they've had and their decisions to either, you know, continue funding or take away funding based on the views of the impact they have. So I'm not going to try to dissect those views because sometimes a lot of these views become very political in nature. But I will look at the effect of some of these decisions. I've always believed it all depends on the goals when it comes to healthcare management. What is the goal of any administration? The general goal, of course, should be to provide the best medical service to all facets of the society, be it the people in the upper middle class, lower class, people in the Medicaid system, people in the private health insurance system. Everyone should have the ability and the opportunity to have equal access to care. So based on that, if the goals of the WHO should be to make sure that that is attained in all the countries, then I wouldn't see why there shouldn't be funding, you know, given to them. That shouldn't be taken away. So I look at everything from that general perspective, because if you try to delve very deep into this, it really does get very delicate, and sometimes it's hard to separate one from another. But my focus has always been that there should be equal access to care. And I look at all the different factors that affect a community, historical events that could have happened to make one community become almost in a disproportionate way receive care versus another community. And I try to you know, put out information and resources to help healthcare providers to engage with those communities to help them build trust, because it all really kind of borders on trust. If we find that healthcare in a particular community, take for instance, I was doing a research on the CDC website, because don't forget that I didn't grow up here. You know, I came here, I went to school, a good part of my primary and secondary education, and even my university, you know, what we call the, I guess, college here, was in Nigeria, you know? So when I came here, I just started from scratch. I have a first degree in computer science. I have a bachelor's degree in computer science from University of Nigeria in Nsukka. So the idea was that I came here and just started from scratch as a nurse's assistant. So as a nurse's assistant, it was pretty much a 9-month program, but versus someone that has a bachelor's degree, but I was ready to put that aside so I could get into a system and observe patient behaviors and observe the different things that had taken place in history that could make patients behave the way they do, and try to put resources out there to help bridge that gap to make sure that everyone in our communities have the ability to have access to a good healthcare management. So the CDC trial I saw on when I was doing my research was on the Tuskegee trial of a couple of men in 1932, when that trial took place to study the natural events of syphilis. As per the report on CDC website, there wasn't adequate consent that was gotten from the group of the Black men that were studied, and there wasn't adequate description of what the study intention really was. So if you look back and see that there is some sort of a mistrust based on these historical events in such community, it always almost makes sense if the healthcare provider doesn't take time to understand this cultural basis and make sure that they engage strategically in a way to build trust and improve engagement and offer the best care possible. So I believe that's part of where we see the discrepancy when it comes to various communities. And this is why I make sure that I'm out there putting resources in the first book that I wrote, the different ways clinicians can engage when patients show up suspicious of the clinicians or opinionated or angry. These are some of the things I focus more on, more so than the public health aspects, of health management.
Mm-hmm. Yes. Thank you, Nonya. Let's turn now back to Edwin, and another question. It was said that even prior to this time that there was something of a shortfall in epidemiologists on the African continent. I believe there are about 1,500 epidemiologists, and for tracking and addressing concerns like COVID and others, it would be said that there should be a quadrupling of that number to better deal with this. Brenda, before she stepped away, and she stepped away, I believe, for a connection issue. But thank you, Brenda, for joining us, and I hope we'll get a chance to speak very soon. Thank you all for taking the time to do this. And again, I'm very honored that we have had a chance to talk. So there is South Africa's public health service is South Africa is quite a large country. It has quite a large economy, and it has a commensurate scale of healthcare infrastructure. Liberia, from whence you hail, Edwin, is a somewhat smaller place. And what is your impression of the needs for the region, for West Africa, in improving this health infrastructure, and perhaps a number of professionals? A lot of folks, when they get degrees, they do travel to other countries. How would you address these concerns of professionals and healthcare infrastructure in West Africa and Liberia particularly?
Well, I mean, that's a very interesting question. How I would address it. So you're pointing out the obvious fact that there's just not that many doctors, right? Yes. And it's largely because you can become a doctor. It's just not that profitable to be here. The main, so if you're talking about increase, well, there's brain drain, but if you're talking about increasing access to healthcare professionals, it's either going to be the people who are going to, have enough money that people want to take care of them, or some government's going to support it. In the case of Liberia, our government does not have probably the competence, but also the capacity to increase our health sector significantly. We just don't. I think our budget is, $600 million, and we even didn't make that, and the IMF supplemented that. Like you can look into the history of Liberia; it's very interesting. But we're particularly poor as a function of some of our recent history. despite doing relatively well 50 years ago or so. So I mean, if you're talking about government funding and you could somehow procure external funding, that's one thing. But again, I think most of the problems with Africa are just infrastructural. Like there's not a lot of context for economies to flourish. The currency systems don't make sense. The roads are not nearly connected enough to allow the governments or just the people to exploit the productive capacities of their various societies. So yeah, I mean, I know the answer is sort of complicated, but or not as one-tracked, I guess. But the question of how do you increase the health capacity of that part of the world, if you're thinking about it from the perspective of our government, it's all about just growing the economy. If you're thinking about it from the perspective of some world government or something, then you could talk about external funding. But then if you're talking about it from that perspective, then we're completely changing the game, and a whole range of policy issues have to be on the table.
And do you think that, I'll pose a similar question that I already asked another panelist, do you think that the World Health Organization should play a role in filling in those additional resources? As you mentioned, there's not an enormous budgetary allocation for public health in Liberia. Is there anything else you'd like to add about these outside organizations or the World Health Organization in that country?
Well, I don't know how much the World Health Organization has donated to Liberia throughout this crisis. I don't actually know the numbers. I'd imagine that there are a range of organizations that could provide funding, right? So the World Bank, the IMF could do so indirectly. I know Liberia had money allocated to it for pandemics. We got some money because of Ebola, and then some of that was left over. So I don't know who exactly provides us that funding, so I couldn't say. But if you're asking me, do you think we should get more funding? Yeah, I mean, I think we should always get more funding. The GDP per capita of Liberia is $700 and something, right? So that means if you lived in a communist utopia where all of the productive capacity were evenly spread out, things that are the goods and services in the economy that are actually produced would only render $700 a year to a person. Now, there are a lot of other things that don't get counted in that, but the poverty is just, heartbreaking. And, the answer to dealing with these questions is just very, very complicated, and it's probably a multi-century process. So.
Yes, and the growth of the African continent at the advent of more advanced technology in this period of the network world has been commensurate with that of the rest of the world. In fact, Nigeria and the continent overall has outpaced the average growth in GDP. So
Nigeria?
Yeah, well, and I'm looking at Liberia GDP growth.
Well, we're a different case because we literally had a 14-year civil war, and before that, we actually had the highest GDP per capita on the continent for a variety of other reasons. Yeah. But,
yes, I only made reference to Nigeria because I know that their economy has grown quite significantly.
Well, I mean, yes. There's also a large distribution issue though, because Nigeria has oil money, right? So if you go to Lagos, there are parts of it where there are nothing but Lamborghinis and mansions, right? But then you go to other parts and people are literally living in dirt, right? So I mean, you gotta dig deep into those GDP numbers. Liberia had the same thing. We had, after World War II, we provided much of the like the Firestone rubber plantation, even during World War II, we provided the Allies a lot of their rubber. And we had a lot of iron ore that we're exporting. And Liberia was doing, for the continent of Africa, we're doing very well. But the money wasn't being spread out. So a few people were, building hotels and mansions and everything, but the money was not being spread out. And eventually that led to massive destabilization. But in our case, it was because it was one tribe of people that had most of the money, the American Liberians. You had 5% of the population that had, food. So that the inequality dynamics were really, really stark. Anyway, I bring up that point to say that when you look at these GDP numbers, it might not be as emancipatory as you would think. And you should really consider the distribution there.
Yes, yes. And that brings me to another question, and I'll pose this question to all of the panelists. Yesterday, I gave a presentation talking about the prospect of a declaration for radical life extension in some particular countries. We're having this proposal being read right now by the health minister of Argentina and also Panama. They are looking at seriously considering this proposal to declare that aging is a disease and should be treated as such, to declare that life extension is an important goal, a mandate of their public health services. And this is something that I think could very much impact an economy of the first country to do this. It could drive a lot of research and development, reverse perhaps some of these brain drain trends, and certainly generate a good feeling and good publicity for the people who do this. However, some people in the United States I have encountered and elsewhere, when I talk about the prospect of longer lifespans or super longevity, they say, you're describing a situation that has not come to pass yet, and there are a lot more pressing concerns for us. We have a lot of failings in public health of a more earthbound and present day kind. And this could be said of perhaps any country. It could be said of this response of folks on the African continent. Any panelists who would care to jump in, as we are coming down to the end of our conversation, nearing the end. Do you think that a declaration of treating aging as a disease would be helpful in your country? And do you think that it is? Do you think that it is something overall that is worthwhile at this time, or do you think that it's an idea whose time has not yet come?
I think it's pretty worthless. Like, most of the life extension that needs to happen in Africa is economic. Like, as in, like, we just need better frameworks for trade, education.
Yes. My feeling is that economic policy and growth that would go along with it is paramount to all of these things. And it doesn't matter really where you are. There's always more work to be done there.
The median age in Nigeria is 18 years.
Yes. Does anyone else have feelings about this? I would urge people to consider that this kind of declaration would be of great value to a country. If you know, we could be in contact with to submit this proposal to. This could. I made mention of this yesterday. A friend from the Humanity Plus organization, a friend of the United States Transhumanist Party, Ben Goertzel, orchestrated a publicity stunt in Saudi Arabia. Yes, he's great. He's a great man and a great artificial intelligence researcher. He orchestrated this unique situation where his robot, Sophia, was the citizen of Saudi Arabia, And this generates a lot of public interest in its business of advanced algorithms in this part of the world, and a peninsula, which is already quite good, but it generated a lot of goodwill for that country. And I think that we could do even better with a declaration of this kind, not only generating good publicity, but bringing a lot of these concerns and representatives into this area that declares aging and disease, and also perhaps triggering not only a life extension, but other public health initiatives that would coincide with it. Does anyone else have feelings about a life extension or publicity stunts of any kind? Anyone care to chime in? Nonya, please.
Okay, yeah, I think I was muted. What I like to see here is any proposals that will help put more emphasis or funding on managing chronic ailments, things like diabetes or hypertension, to toward the extension of life. It's a good proposal. If it's called, we call it more aging, declaring aging as a disease, and make something that will put emphasis on better management of chronic ailments, then that is something that will life and living life to the fullest, but living a good quality of life in terms of healthcare management.
Mm-hmm. Yes, and Brenda has her hand up. Hello, Brenda. Welcome back. What is your impression of this kind of initiative for South Africa, or any other things like this?
Yes, I think it is a great initiative. But I think before we can even get there, we need to ensure that the health system is improved. We need to make sure that we've got the right infrastructure, because there's a whole lot of elements or factors that lead to a whole lot of illnesses, a whole lot of these systems being dysfunctional. So you cannot start to think about prolonging people's life when you know that health is going to be a problem. So first of all, from what I understand, reading about longevity and the benefits that goes, the fear that is there is the fact that yes, you're going to live longer, but are you going to be healthy? What about the quality of life? So as it is, with the infrastructure that we have, with the kind of services that we have, processes that we have, lack of investment in the health sector, it makes it very difficult for people to even want to consider living longer, because you've got people that have got chronic illnesses, you've got people that, as it is, sanitation is a problem, simple things like that. So if it is an initiative that needs to be taken forward, I would suggest it has to be coupled with a lot of education in terms of the support structure, what is required to enable it to be successful. What is it that we need to do from a medicine point of view? What is it that we need to do from a technology point of view to kind of prepare ourselves already us to be able to take something like this on? At this point in time, I think there's still a lot of work that needs to be done on the ground first before we can get there. With new initiatives, my suggestion, and this is just my opinion, is that, because there's pockets of excellence in any country, in any continent, maybe it should be, tested or tried in a reinforced area, which is already at a level that is, getting the right infrastructure, the right health. So that becomes a proof of concept to show that, this thing really does work and these are the benefits of that. So that it encourages governments or the private sector to be able to say, you know, if we did 1, 2, and 3, we will be able to get there. And this is the benefits that we will get if we push an initiative like that.
Yes, and what you've said there about the importance of WellSpan, I think that this is an important concept for life extensionists, and also it goes hand in hand with improving public health outcomes in other areas. It is why I feel that it is not so strange to advocate for both of these kinds of things, all of these kinds of things in tandem. Mr. Orji, how are you, sir? We haven't forgotten you. You are a futurist. I've been lucky enough to be on a panel with you before. Tell us a little bit about your impression of life extension and perhaps what you see the future of life extension for Nigeria being. Are you still there? Yes.
Yeah. Okay. The declaration is a welcome one. It's a positive one. But, you know, like here in Nigeria, we have a lot of fantastic laws, a lot of laws, declaration without implementation. It's not just about the creed, declaring. It is also about implementation. Yes, talking about the declaration is a good one because most especially here in Nigeria, the life expectancy rate in Nigeria has dropped up to 45. As far as you clock up to 50, you start having a lot of illness, and some of them are not, you don't even know. And here in Nigeria, a lot of people don't suddenly go to hospital. Some people because they can't afford the money. Some people based on religious reason, because we are very incredibly religious over here, and some other factors. I think it's a welcome development because just declaring it, making it compulsory. To me, if I'm the governor, making it compulsory, or if the president, making it compulsory. If you are 60 years old, you must go to the hospital. My dad last year died of heart-related disease last year, and he died because it was actually mismanaged. And I think if we should have this kind of awareness, if you clock up to 50, you are vulnerable to certain disease. We should tell people, especially here in Africa, it's not going to the hospital does not mean that the government is labeling you to be a dead person or you are going to die in 2 years to come, but is in order to help you to live longer. And but that is not going to happen. Even if we declare it here in Africa, it's just going to be one of those creed on paper that has not been demonstrated actively. And I want to debunk something away from that. Nigeria is not a rich country. Nigeria is not a rich country. We are not rich. And yes, you can say we have a lot of potential, but we are not a rich country. A rich country that cannot, where citizens can't survive if they can't work up to 2 weeks. Those people, the people, they are not rich. We are not rich. And yes, I want to, the public health here in Nigeria, we sort of have a brain drain because most of our doctors are not here, have emigrated to United Kingdom, to other African countries, smaller African countries, to United States. It is reported that in every week in UK, 12 Nigerians are being employed in UK. And why is it that people are leaving the country? Because of the public health sector. To practice here as a medical practitioner has been made less attractive. Poor remuneration, poor incentive, poor infrastructure. You go to some hospitals, general hospital, somebody told me, a prominent politician in Abia State told me 2 weeks ago that in the whole general hospital, there is only one functioning ventilator. And this is the kind of experience we have in other African countries, not just in Nigeria, in other places. We have poor facilities. We have poor facility. And I'm also going to stress it out to other partners, NGOs. It's not just about giving money. You don't just give money. People are donating money to the federal government and it is being mismanaged. Like I read on papers this morning on the dailies, the Kano State governor was appealing to people that he needs about 15 billion naira to fight coronavirus. Why? You need 50 billion naira to fight coronavirus and you have only 5 reported cases in Kano State. What do you need 15 billion naira for? You know, some governors are just using this as an avenue to loot the treasury. And this is what has been happening. We have been having this kind of issue in our health sector, in other sectors. NGOs, money have been given now, like last 2 weeks, the EU donated 50 million euros to Nigeria. Can the federal government of Nigeria, can they account for it? The same thing with other African countries. The problem here in Nigeria or other African countries is not about human resources. It's also about corruption. And I must stress it, if any partner, you are giving money to the people, make sure they are being accounted for. And you might not necessarily donate the money. You can set up your offices here, do it by yourself, monitor the program. If you should donate money for ventilator, why can't you buy the ventilator and give to the hospitals? And I think also we need a training of our officials. Like some of our health officials should be updated. We have health facilities even in the rural area. Here in Nigeria, one doctor in the rural area, one doctor is like for 22,000 people. We have 42,000 doctors in Nigeria. A population of 200 million people. We don't have enough doctors. Here in the cities, you get to see people, one doctor taking care of about 10,000 people below the World Health Organization standard. The World Health Organization standard states one doctor, at least 600 people should be taking care of 600 people. We don't have that because people here in Africa, it's not as if we don't have the resources, we don't have the manpower. We have it. They are leaving the country to United States of America, to UK, to other countries to work for them because they can't, here is not an enabling ground. Here in Africa, they are working in United States of America, in Canada, in Australia. So the problem with Nigeria or most African countries is issue of leadership. Issue of leadership and poor leadership. The issue is poor leadership. You see some doctors here in Nigeria, they are living in rural areas. You ask them to go to rural areas. I have a friend, he's a doctor. He said he can't go to rural area because you see some rural areas, they have bad roads. The roads are not motorable. You can't go there. You want to, some of them, if they go there, they are being kidnapped. In Port Harcourt, doctors are being kidnapped. In Benin City, doctors are being kidnapped. The same narrative you get in other African countries. So the problem, in a nutshell, in summary, to get it right, I have a lot of jottings over here, but I don't really have time. There is no time here. I did a very extensive research, and this is something that that bothers my mind every day, because the problem here in Africa, it scorches the mind and sickens the conscience, especially here in Nigeria. It touches the mind and sickens the conscience. A friend of mine, his sister gave birth to a twin, and prematurely, I went to the Lagos Teaching Hospital. One of them died because of the hospital had only one ventilator, only one oxygen. One of them died. And this is the precarious situation we have in Africa. Money are being budgeted, the small money that are being budgeted are being looted. Okay, check Nigerian budget for 2019-2020 to our health sector is not more than 60 billion. But the National Assembly, they budgeted more than close to 150 billion to renovate the National Assembly. It's issue of priority. We have to prioritize our health sector. I said the COVID-19 experience is a salutary experience because most of our leaders, most of African leaders don't have anywhere to go to. They don't have to go to United Kingdom or United States for health service. They are here in Nigeria. And will I say glory be to God, one of Nigerian top public official, I won't mention his name, is dead. Perhaps if we have a better health sector here in Nigeria, his life will have been spared. The problem the problem with Africa is corruption. And I'm also sounding this as a warning to other NGOs. If you are giving African money or giving African government any money, make sure it's being accounted for. And if you have the means, you can go yourself, set up an office here in Nigeria or any other African country and do it by yourself and recruit people, train people. Let's retrain people because we don't have enough doctors. We can actually update our nurses. Some of our nurses in Nigeria, there's what we call some quack nurses, but they are not well trained. We can retrain these people to manage some of these issues because doctors can be everywhere. If Nigeria want to meet up with the WHO standard of, for instance, if we should produce 30,000 doctors every year, it will take us 25 years to meet up with the WHO standard of having one doctor to 600 people. So that's it. I think the problem with Africa here is issue of accountability. We should make accountability, better funding and better incentive. Our government should prioritize health sector. If our government prioritizes health sector, Nigeria will have the best health service in the whole world. I mean it. There was a time here in the 70s where the Arabian leaders, people even from UK come here for medical checkup. Go and check the history. It's just because of irresponsible leadership. Sorry, I've said enough. It's something that's have been in my mind so long, and I really prepared for this conference. But because of paucity of time, I can't be able to download everything I have. Thank you.
Yes, no, thank you, and thank you so much for these insights. Going back to the COVID statistics specifically, we know that there's 26,000 confirmed cases all across the African continent, a relatively low number, and we know that some of that is owing to the good work of folks like Brenda and folks in South Africa who have done had a very good deployment in flattening the curve and doing what needs to be done in this situation. But there are still projections that say that these infections and deaths could ramp up into the millions of infections and hundreds of thousands of deaths, conceivably over the course of the next 6 months. So I think that it is important to consider what course of action might be done here. Edwin, you have your hand up, sir.
Also, Ben, Malak has also been trying to raise a hand, but she's the host. She doesn't have that facility. If you could, thank you.
Yes. How much time do we have?
We're overrunning by about 20-something minutes, but the next speaker is on, and he's been enjoying the conversation. So we have a little bit of time, probably until the 1:30 mark.
Okay, we'll wrap up in the remaining minutes. Well, let's hear from Malek. How are you?
I'm fine. How are you? Good to see you again.
It's good to see you. Yes.
Thank you. I just wanted to recap on what Aubrey said, because here I had a post before on the ventilators numbers. I posted on LinkedIn. It's based on statistics. In South Sudan, 11 million people, they have only 4 ventilators, and they have 5 vice presidents. This is what is going on in Africa. The funding from the NGOs and the help is coming from outside of from the international community is not enough, because what is going on is like the funds that are going and in corruption, they are taken in people's pockets, and that's one of the main issues that we have. And it's a vicious cycle how to build Africa, but at the end of the day, it needs to start from killing the disease of corruption from the first place. So that's what I wanted to add to what Aubrey said. But I have a question for you, as you are a politician. So what I wanted to ask you is how, you know, health sector and it's one of the main general interests that the state is protecting and controlling, like as the vital general sectors that they are really related to the public interest. So how can the state make a balance between the public interest and the liberalization of telemedicine? Because it's now we see that telemedicine it's vital. It's been used in the management of COVID-19. It should be used also to liberalize and to make access to everyone in the world, because access of private actors into telemedicine can have a positive impact, not only in the countries that they are situated in, let's say the West. It can work as a humanitarian activity into Africa with the spillovers. So how can you like propose as what you think that the governments need to make it happening while balancing the two general interests, knowing that private actors will always tend to go for profit more than social return on their investment?
Yes, that last point that you made is an unfortunate reality, and reflects many of the problems that we have in the United States with public health in this for-profit model. Edwin, who we'll get back to in just a moment, alluded to this before, that there is just not the funding for these programs in every part of the world, and we mentioned this in the context of Liberia. And so some lower cost approaches like telemedicine programs, like mobile clinics, which can fill in the gaps of with the existing public health infrastructure. These are, I think, the best approaches for the developing world, and that's one person's opinion, to see that this a fully realized public health service can be pieced together from using those technologies. And I'll say that this is a feature of emerging technology and advanced technology across the boards, is that it does lower costs, and it is allowing for more sophisticated usages. So we should always try to find ways to see that is the case. And telemedicine, I think, is an excellent example of that. And I'll go back to Edwin briefly, and I do want to hear from Kelvin again as well. We haven't heard from him in a while. But Edwin, please, you had your hand up.
What I had my hand up to was some time ago, but I think the broader point is that life extension in Africa has more to do with infrastructural level investments, right? We need to be able, like our governments need to be able to deficit spend if we're gonna build infrastructure. We don't have the capacity to do that. When you're talking about accountability and the impetus for accountability, when you're in an environment with that much scarcity, all the incentives are for people to steal when they can steal. So I think blockchain technologies are going to be really important in that regard, making sure that we can just build into how resources move around accountability. But I think, you know, if you're talking about life extension in Africa, and that's something that you're interested in beyond life extension technologies, then it's all about education, period. Because that's like the fundamental thing that you can change before the other things can change. That's all.
Yes. Brenda, you have your hand up. Please, what would you like to say? Brenda?
I spoke about ethical leadership, and it's not only happening in Nigeria where corruption is rife, and especially among the public sector. I mean, yesterday or about 2 days ago, when in South Africa, the stimulus package was announced for the COVID relief. Most of the people, the first thing they said was, we hope it reaches the people that it needs to reach. Because what happens is that at the higher level of government, that's where the corruption happens. So I think, if we can work within our different countries to ensure that, we minimize corruption and ensure that, leaders start to act more ethically, that is when we will start to see the shift happening in terms of, if there is investment or funding coming into the country, it goes to where it was intended. I like the point that was made earlier on to say that, it's not only about bring the money in and just leave it there. Ensure that the implementation happens. I mean, in the government itself, I mean, there's budget being allocated, but then what you see is that, there's no follow through in terms of, if I've given you this budget, have you made sure that it has, achieved the goals that it was meant to achieve? That doesn't happen. So there's no political will, there's no action, there's no implementation, and there's no monitoring as well or review to say, have we done what we have intended to do? And as well, I mean, I speak a lot about inequality because that's the biggest thing as well, as far as African countries are concerned. The sooner we start to narrow that gap, the better it will be for everybody to start benefiting from all of this. So we can get all the help that we can get, be it from the World Bank, from IMF, from wherever. But as long as there is no will to act in our different countries, and the corruption is still at the level where it is, it's not going to help anybody. It's not going to help the health sector. It's not going to help any other sectors. And again, when we go back to talking about investment in health, we focus more of our budget, or the money goes a lot to other sectors, forgetting that if we do not have these people, we're not going to be able to achieve those goals. Starting to shift that and ensuring that health becomes a priority for each country, I think it will help us to get a step closer to making it better for all of our African citizens as well.
Mm-hmm. Yes, and this is an incredibly important point. I'd like to just briefly call back the question that I asked before about life extension, and I understand the skepticism of this subject. I think that that's a healthy impulse. It's often been said that of the African continent, about 2% of the medical products that are consumed on the African continent are produced there. And I again think that perhaps this life extension declaration, were it to occur in an African country, could not only spark public interest in broader public health goals, but also in research and production of this kind in that locale. Does anyone have any thoughts on the access to medicine in Africa, and what can be improved there from a production and a supply chain standpoint? Aubrey, you have your hand up, sir.
When it comes to access to medicine, drugs, is something most African countries are still battling, especially here in Nigeria. I served in northeastern part of Nigeria, one of the most ravaged by poverty and insurgencies. And I undertook a lot of humanitarian work. Apart from being a lawyer, I did doing legal stuff, going to court to represent indigent people, indigent clients. I also partook in some medical outreach with some doctors. And I've had a first-hand experience of how difficult it is for people to access medication. Because number one is, this is a country that a lot of people, or a continent that a lot of people are poor, very poor. People can't even procure medicine. Then in Taraba, I could remember very vividly where I had to pay for people's, a lot of people's medication. I lost a neighbor because she took cancer, to hepatitis that developed to cancers, something like that, because she could not go to hospital. She did not have all the money to go to hospital. And then this amount of money, the money she needed, is less than $10. Is less than $10. And when she went to the hospital, it was too late. And the same thing, the former emir of Kano, Sanusi, he once narrated a story of how one woman who came to his palace to beg for for money to take her son to the hospital, was in the palace lining up, queuing up to meet him. Before he could meet him, the child died. So the problem here is issue of poverty. There should be an action plan by the government to be able to subsidize these drugs for the poor people. Okay, look, for instance, issue of HIV/AIDS. Even there in Taraba State, they have high number of HIV patients, and some of them can't even access HIV drugs. Because some of these drugs are being given, instead of the WHO have made this drug affordable to people, free to people, but some hospitals, some government hospitals still hold it and demand money from people, and some people can't get it. And again, even not just HIV/AIDS, we even have cancer. Can you remember, we have only 5 hospitals in Nigeria that can treat cancer all over the country. Only 5 hospitals. Only 5 hospitals that can take care of cancer. The whole of Nigeria is on record. And the same thing, the same narrative you get in other African countries, most African countries, or worse than that. Again, when you go to local, some of our people are living in rural areas. Some of these rural areas don't have hospitals. You go to some of these rural areas, you see all kinds of sicknesses, terrible sicknesses, all kinds of sicknesses. And these are the simple sicknesses that they can actually be simple surgeries. Ben, as an American, these are sicknesses that you don't even know they exist. But in Nigeria, they exist because our leaders are not responsible, because we as a people, especially our leaders, are not responsible enough to these indigent people. So there should be, I made mention of we don't have enough doctors. We don't also have enough health facility. We should promulgate good health facilities, widespread health facilities, especially in the rural areas, because these people in the rural areas, they can't access these hospitals. And again, even when the ones they can even access are, they call chemists, they're just mini pharmacy, and some of them sell fake drugs. Here in Nigeria, we have plethora cases of fair drugs. A lot of people have died of fair drugs. During the Obasanjo administration, he actually started up to fight these first drugs, and we know how huge this particular menace, how huge it is here in Nigeria when it was uncovered. So we should take issue of health seriously, especially to the downtrodden. I can be able to, if I'm sick of malaria, I can get health service. I can procure it. But there are some people here in Nigeria that cannot even procure, that can't have money to get a malaria tablet. So we should actually look into this thing and be sincere to ourselves. Nigeria, Africa, most African countries, we are still living in poverty, abject poverty. Polio is still ravaging the north. We still have issue of Lassa fever. Do you know that Lassa fever have killed more than 500 people in Nigeria this year? Lassa fever alone. So these are the things we have to talk about. It's not just about talk. We have talked enough. We have said a lot of things enough. And the main problem is we are poor. Our people are poor. We should take that into cognizance. Our people are poor, and most of our people are living in rural areas. We should make sure that we have health facilities in those rural areas. We should make sure that we have doctors in those rural areas. And again, some of our NGOs should take their medical outreach to these rural areas. They have been trying, some of them have been trying, but we still need to do more. We still need to do more. Even here in the cities, a lot of people cannot be able to eat, not to talk of procuring malaria tablets. And malaria is a common sickness here in Nigeria. Malaria has killed more than HIV/AIDS. So we should, maybe some of these sicknesses, some of these notable sicknesses, the drug should be free. Like malaria should be free. And some other drugs should be free of charge. Our government can do it. African leaders can do it. All these important, all these common diseases, their drugs should be free. Henceforth, polio drugs should be free. And it should be...
Good. All excellent points. And I would love to continue this conversation with all of you, and I hope to have interviews with each of you in the future. We are quite nearly out of time, but we should leave on a high note also by saying that public health care and infrastructure has improved substantively in particularly in urban areas, but around across the African continent over the course of these last 2 decades, just as there has been that substantial GDP growth. And it's true, as a panelist pointed out, that there are distribution and inequality concerns there, but that growth has been quite large. And there have, of course, been substantial reductions in the number of people that do not have access to potable water or healthy food. But these concerns still remain, and it is a very good point to say that that all of these concerns derive from serious economic considerations. I want to thank you all for your wonderful insights and this really lovely conversation. It's been an honor for me to sit at your feet and hear what you have to say on these subjects, and give me some understanding of your experience and your work in your respective countries and fields. And I thank you again, all of you, for tuning in to this conversation. And please continue to support TAFFs and their good work in these areas, and enjoy the remainder of the conference. Thank you again, Brenda, Nonye, Orji, Kelvin. I'm sorry that we didn't get more of a conversation, but I do thank you so much for your contribution. Edwin, thank you so much for this lovely conversation and incredible insights. Thank you all. Thank you, Edward. I give you the floor now, and enjoy the remainder of the conference.
Thank you very much. Thank you for such a lively debate. I wish I could have allowed it to go on for much longer, but our next, so that we don't throw out the rest of the day, we do have to move on to the next topic. Fortunately, Hans has been enjoying the conversation and the debate that's been going on. His topic is on telehealth in Africa. He's here on the line now, and I'd welcome him. He's both CEO and co-founder of the Universal Care for the Africa Foundation. And I'm sure if the panel and the others are able to remain on, then I'm sure that we should be able to have quite a few additional questions. Hans, just unmute you. Are you there?
Okay, yes, I'm here.
Welcome. Did you want to share your slides? I've got them ready, but you're more than welcome to share your screen.
Sure. Okay, 1 second here. Are you able to share them, or?
I can share them if you would like me to. Yeah.
Yes, please. Yeah.
Just give me 2 seconds.
Okay, thank you so much. Thank you very much.